The platelet count represents the actual number of thrombocytes in a given volume of blood. Platelets are small fragments, they're tiny, round, non-nucleated cells formed in the bone marrow. They circulate in the blood, monitoring vascular health and responding rapidly to vessel injury. By clumping together at injury sites, platelets prevent bleeding and kick off the coagulation cascade. Without platelets, even small injuries could result in serious bleeding. Because of their short life cycle, platelet levels can change quickly, reflecting both production in the marrow and destruction or consumption in circulation. Normal platelet counts vary based off of age. In adults and children, the expected range is 150 to 400,000 per cubic millimeter of blood. Infants have slightly higher values, and premature infants can have lower counts as low as 100,000 due to immature bone marrow. Newborns stabilize between 150 and 300,000, and knowing these ranges can help distinguish between normal physiologic variation and true pathology. Critical platelet thresholds must be recognized as a platelet count below 20,000 per microliter is dangerous and carries a high risk of spontaneous bleeding, including intracranial hemorrhage. On the other hand, counts above 1 million can significantly increase the risk of clotting and thrombotic events. Both extremes require urgent evaluation and hospitalization. We order platelet counts whenever there's suspicion of a bleeding disorder or bone marrow problem. Indications include unexplained petechiae. This is when we have non-blanching red rash or red spots, especially seen on the lower extremities. Spontaneous bleeding, unusual heavy menstrual periods, or suspected thrombocytopenia. Platelet counts are also used to monitor patients undergoing treatment for bone marrow suppression or thrombocytopenia, such as those on chemotherapy. And because platelets play such a key role in hemostasis, tracking their levels is essential for acute and chronic care. Again, we have the same draw instructions because they're part of a CBC, lavender tube, no fasting EDTA. It's important to follow up, though, if there are abnormal results relatively quickly. This is particularly important if platelets are critically low. In those cases, we observe for bleeding signs, check for hematuria, inspect for bruises, petechia, gum bleeding, epistaxis, and reassess venipuncture sites for hematomas. Recognizing clinical signs alongside the lab values will ensure that patients remain safe. Several factors can affect platelet counts. There is a 10 to 15% margin of error due to platelet clumping in the sample. This can make the count look falsely low. Strenuous exercise can also temporarily increase platelet counts, while menstruation just prior to testing can lower them. Living at altitude can also increase platelet levels, reflecting adaptation to lower oxygen availability. And many medications can affect platelet counts as seen on this list. Of note, estrogens and oral contraceptives can increase platelet counts inappropriately. Thrombocytosis is the word for elevated platelet count, and it can derive from both malignant and non-malignant causes. Malignancies such as leukemia, lymphoma, or solid tumors often stimulate the bone marrow, increasing platelet production. Iron deficiency anemia is another important cause. While iron is not required for platelet production, the bone marrow overactivity in iron deficiency tends to drive platelet counts up. Polycythemia vera, a disorder involving all marrow cell lines, also increases platelets. Finally, post-splenectomy patients often have high platelet counts since this spleen normally helps remove old platelets from circulation. Thrombocytopenia, or low platelet count, has many possible causes as well. Thrombotic thrombocytopenic purpura is a rare but life-threatening condition involving platelet consumption and hemolytic anemia, versus immune thrombocytopenia occurs when antibodies target platelet antigens, leading to their destruction. This was the lowest platelet count I saw in my clinical practice was a platelet count of 2, and it was due to an ITP, an idiopathic thrombocytopenic purpura, where the patient was having autoantibodies against their own platelets. Hemolytic anemias can also involve platelet destruction alongside red cell loss, and hemorrhage, especially significant or ongoing bleeding, reduces platelet counts as they are consumed in clot formation. In all these cases, the patient is at risk of severe bleeding complications. Additional causes look similar to some of our other conditions we've seen, such as systemic diseases, autoimmune diseases like lupus, vitamin B12 deficiency from pernicious anemia can lower platelet counts. Chemotherapeutic drugs are another major factor as they're toxic to the bone marrow and can decrease platelet production. And hypersplenism, or an enlarged spleen, also leads to increased platelet sequestration and destruction. And in each case, the underlying mechanism is different, but the result is the same: reduced platelets and an increased bleeding risk. The slide lists an additional cause of thrombocytopenia. Disseminated intravascular coagulation, or DIC, is a very serious condition in which widespread clotting consumes platelets, leaving the patient at high risk for bleeding. Bone marrow disorders such as leukemia or myelofibrosis replace healthy marrow with abnormal tissue, reducing platelet production. And inherited disorders and autoimmune conditions like Graves' disease can also reduce platelet levels. Together, these examples remind us that thrombocytopenia can signal a wide variety of underlying diseases. And here again is a nice happy video or happy image to help remind you about what do platelets do when they form a platelet plug.